Okay, let's unpack this. Today, we're doing a deep dive into something pretty fascinating in medical imaging. FDG PTCT scans.
hmm
Based on the material we've looked at, these scans are incredibly powerful, right? Almost like a metabolic fingerprint for disease, especially cancers.
They really are. They give this unique view of how cells are actually behaving.
But, and here's the catch, what if some of those fingerprints aren't quite real? What if they're sort of phantom prints leading things astray?
Well, that's exactly it. Despite being so sensitive, these scans, they're vulnerable to what we call artifacts and pitfalls.
Okay.
And these aren't really diagnostic errors like a mistake someone made. They're more like phenomena. Things that can mimic disease, make healthy tissue look suspicious,
Or hide something real.
or even hide actual disease,
Yeah.
which, could potentially lead to a misdiagnosis or maybe even unnecessary procedures down the line.
Right?
So our mission today really is to help you understand these hidden challenges and see the kind of meticulous detective work experts have to do to navigate them.
Okay, detective work. I like that. So where does it get really interesting? Let's maybe start inside the scanner itself.
Good place to start.
You hear about attenuation correction artifacts. That sounds technical, but how could something common, say a hip replacement, cause a problem?
Okay, yeah, absolutely. So imagine you have a metal implant, like that hip replacement, or maybe even just dense IV contrast dye sitting in a vein.
Uh-huh.
The CT part of the scan, its job is partly to estimate how much the PT signal gets weakened or attenuated passing through your body.
Okay.
But things like metal or really dense dye, they can cause the CT software to kind of overcorrect.
Overcorrect. How so?
It basically creates fake hotspots on the PT image.
Yeah.
Makes it look like there's intense metabolic activity right where the metal or dye is.
Ah, so it's not real activity, just a calculation issue.
Exactly. It can really send doctors down a diagnostic rabbit hole thinking there's something there when it's just an artifact of the correction.
Wow. Okay, so how do the experts, the detectives, tell the real signal from this illusion?
Well, one really crucial tool is looking at the non-attenuation corrected images, the NAC images.
NAC, non-attenuation corrected. What does that show?
Think of it like the corrected image is a photo with a filter applied, maybe making it look sharper or brighter.
Okay.
The NAC image is the raw photo. Before any filters, it shows the pure PET signal, the tracer uptake, before the software tries to adjust for density.
I see. So you compare the two.
You compare them, it lets the experts see if that hotspot is actually real metabolic activity or if it's just a side effect of the scanner compensating for that dense metal or dye.
That's clever, almost like seeing the behind-the-scenes data. Okay, so that's an issue with the correction process. What about movement? You mentioned the patient.
Right, yeah. Motion and misregistration artifacts. This is another big one.
Because the CT is fast, but the PET is slow.
Exactly. CT scans are super quick, often just a few seconds, maybe while you hold your breath.
Uh-huh.
But the PE part, that takes several minutes for each section of your body they scan. And during that time, you're usually breathing normally.
So things move.
Things move. Organs like your liver, or your lungs especially, they shift with breathing.
Okay.
So this difference in timing and position between the fast CT snapshot and the slower PET scan means, say, a lung nodule might look like it's in a slightly different spot on the combined PT-CT image. Or even look like it's jumped into a nearby organ, like the liver or the adrenal gland, if the movement is significant.
Whoa.
Yeah, it creates this puzzle, because you might see a PE hotspot, but when you look closely at the CT, there's no actual lesion or structure right there to explain it. It's misregistered.
Fascinating. So the physics and timing are critical. What about the injection itself? Can just getting the tracer cause issues?
It absolutely can. We sometimes see FDG hot clot artifacts.
Hot clots. Sounds dramatic.
It does. They're basically tiny blood clots that can form right at the injection site, maybe if there's a little blood drawn back into the syringe.
Okay.
These tiny clots trap the radioactive FDG tracer.
Oh.
So when they travel, often to the lungs, they light up really brightly on the PT scan.
Mimicking what cancer spread?
Exactly. Mimicking lung metastases, which is obviously concerning.
But they're not actually cancerous?
No, it's not the clot itself being metabolically active. It's just holding on to the tracer it picked up during the injection. The key clues are they don't have a matching lesion on the CT scan.
No anatomical correlate.
Right. And sometimes, if you were to rescan later, they might even be gone. So meticulous injection technique, really careful, avoiding any blood aspiration, is vital.
Makes sense. So we've got scanner physics, patient motion, injection technique, but sometimes it's just your own body doing normal things, right? Physiological uptake.
And normal variance.
Yeah.
Yeah, this is a really big category and super relevant for you, the person getting the scan.
Like the vaccine example. That seems quite topical.
Definitely. Post-vaccination lymphadenopathy. If you've recently had, say, a flu shot or a COVID vaccine,
Right.
the lymph nodes in your armpit or near your collarbone on that side can light up intensely on the peaky scan. It's just your immune system doing its job, responding to the vaccine.
But it looks like.
But it can look exactly like cancer spreading to the lymph nodes.
So context is everything.
Absolutely paramount. Knowing the patient's clinical history, asking, have you had any recent vaccinations and where, is so important to avoid misinterpreting that signal and maybe ordering unnecessary biopsies.
Are there other common normal things that light up?
Oh, plenty. Even simple things, like if you were chewing gum before the scan, your jaw muscles might show uptake.
Really?
Yeah. Or sometimes brown fat, especially in colder weather, can light up. And even your spinal cord has normal areas of higher uptake, consistently around certain levels like C4 and T11, T12. They're just metabolically active areas.
Wow. So it's not just about finding spots, but knowing which spots are expected, which are artifacts, and which are truly suspicious.
Precisely.
So pulling this all together, what does this mean for you, the listener, who might be getting one of these scans? What's the takeaway?
I think the main takeaway is that interpreting these images is, well, it's a complex blend of science and art. It's definitely not just looking at pictures. It demands a really deep understanding of the physics involved, of human physiology, anatomy, the patient's specific history, even recent things like vaccinations or infections.
It's a holistic view.
It has to be. This comprehensive approach is absolutely essential to make sure you get the most accurate diagnosis possible and, the right management plan based on that. It really highlights the expertise working behind the scenes.
Yeah, it really does. A constant learning curve for them, clearly, to stay on top of all these nuances and ensure the best care. So, thinking about all these invisible influences we've discussed, what stands out most to you? And maybe for our listeners, how might understanding these artifacts shift your perspective when you think about diagnostic results in the future?